Panel session entitled Cultural Influences on Mental Health and Coping Among Black Men. I am honored to be the moderator for this session. I'm Roland Thorpe. I'm a professor at Johns Hopkins School of Public Health, and I am one of the co-directors of the Emerging Scholars Program here with Black Men Brain Health. Today, I'm very excited about the opportunity to further engage in conversations based off what we saw earlier for the magnificent presentation. Let's pause for a moment and give a round of applause for Dr. Turner in that presentation. So let's pause for that. Excuse us for a moment. We're just trying to make sure that the fellas stay hydrated. There you go. Thank you. All right. Thank you. So what we're going to do, how we're going to be organized here is I have a few overarching questions from the presentation, and then we're going to open up to a question and answer. And I do recognize there were two people in the room that had questions. We're going to get the questions from those people, and then there was a question from online for which I will read that question to you. So let's go ahead and get started. One of the biggest things in your presentation, Dr. Turner, that I took away from the talk is that from the solutions is that we need to have culturally competent providers. And so the question I have for the panel is what does the training look like for someone to be culturally competent? And does it have to be someone from that racial or ethnic group for that to be culturally competent?
All right. So cultural competence is oftentimes an ongoing process, just like any other level of competence, right? Most professionals, we have to maintain a certain number of CEUs and things like that annually. And as a psychologist, we only have a 2-hour minimum requirement for multicultural competency in our CEUs, right? Which is decent because it's pretty direct, right? And so when we talk cultural competence, it really starts in our training programs. I've worked with a couple groups here in the city in our medical setting to do some conversation with them. And what we find is that, most of the time there's very little conversation about bedside manners or cultural competency and provision of care. So we have to really look at our training programs. That's the first thing I would say. What that means is where are people going to get the training, right? Are we practicing in place where people are culturally different from us, whatever that might look like? It does matter who's doing the training, right? Who's the professor? Who's in the room? What is their level of ability or capacity to do that training? And then it goes into the desire of the person, right? A mentor of mine once said that, the best people make the best providers. And what he meant was, if you're not a good person already, you're probably not going to be a good provider because you don't think about people. You're not a person who's genuinely aware or caring for individuals. So the point would be is like, one, who's doing and providing the training? When does the training start? And then ultimately, how often does the training occur to keep people abreast and up to date with what's happening?
Thank you. Dr. McBride, do you have anything?
Yeah, so currently in my current role, I'm training doctoral psychology students to become neuropsychologists. And in all of my lectures and content, I'm always incorporating talking about cultural issues related to assessment and therapy. And I've beat the theory into their brains. And so they're gonna go out thinking this way, but then also it's like, well, how often are they gonna be interfacing with patients who are different from them? And so I think to what the Dr. Turner said is, in terms of the exposure and the opportunity to receive supervision from Black supervisors. One of the things the question I want to ask my students at the beginning of a semester is, how many times have you had a Black professor or a professor who is of a different cultural background? Do you understand their idiosyncrasies or their idioms, their nuance? Do you understand how it is to interact with people that are different from you, whether it be administrative staff or support staff and the patients? And so if you're uncomfortable in those situations, that's gonna show in how the care you provide for patients who may have a different background. A lot of the students that I train, I know that they're gonna go back to their communities where they come from. And the majority of them are white women. And so I know they're going to go back to the communities where they're treating patients, but most of the patients are going to look like them, right? And so part of our job is to make sure that they're getting experience from providers, supervisors, people that are going to train them to be able to work with and be comfortable with patients who don't look like them.
Thank you. Dr. Brown, do you have anything to add?
Yes, I definitely would agree with my colleagues up here. I also would add that I think cultural competence has to be a value overall, so it includes the faculty, it includes the individual. And I think as an alum of Xavier's psychology undergrad program and of Xavier's counseling program, I saw consistently the faculty and the institution itself really value cultural competence. Later in my career, I learned that competence really could be defined as knowledge, skill, and awareness. And really focusing on having that kind of culturally sound knowledge and making sure those experiences are sound within those different settings in the community, working with different populations, and also helping future counselors and therapists to grow some kind of self-awareness and accountability for their own cultural identity, and to make sure that that is something that they're creating space for also within their clientele. And I think that happens in the coursework way before they actually get into the setting of working as a counselor or therapist. So I think cultural competence and having a real sound understanding of value for it has to be really important too.
If I can.
Please, please.
So Dr. Bro just reminded me of a model. The acronym is ASKED, A-S-K-E-D, awareness, skills, knowledge. The E is for engagement. And the first three are spot on, and I do those. The engagement piece is where do we get practitioners and providers to engage in communities that are culturally different, right? So that's the training, but it's also like being in community with people to know what are the things that people endure and experience, right? And then the last one, D, is desire, which I hit on, but that's what I say, what is the desire of individuals to do this work? And then Janet Hayes has a model, the addressing model, and it's that word addressing age, disability, physical disability, non-seen, race, ethnicity, sexual orientation, systems of belief, indigenous status, nationality, and then gender. So those are two models, addressing and the ASK model, that I use to guide students in training.
Great, great. Thank you. Now I want to pivot and just ask another question and bring it more focused on Black men. And this is to each of you. How important is it to have a workforce or build capacity for a workforce that has the ability to deal with issues that are specifically focused and targeted to Black men?
So a lot of my work is focused on dementia evaluation. So I do neuropsychology and assessments and things like that, where see a lot of patients come through. And I think in 2050, the number of older adults is going to be its largest ever, or probably is already, I think, 2030 or to 2050. But then also the number of BIPOC individuals who are 65 plus is going to be its largest ever. And so in terms of, for me, focus on aging, we're going to have more BIPOC individuals who are experiencing, issues related to aging than ever before. And so, that means that Black men are included in that. It's a hard sell sometimes to tell a Black man hey, you should prioritize your health. What? Like that goes to the antithesis of what a lot of the Black men that I have conversations with in the community, there's no time. Where do I find the time? And so I try to take a practical problem-solving approach to say, if you invest that time into addressing this issue, it's going to pay off in the long run so that you can have more time to do the things that you want to do or enjoy. So like a behavioral approach to this leads to this, and this is the outcome, because I think sometimes it's hard for Black men. They know that they need to take care of their health. I think most people know that, but it's like, when do I find the time to actually prioritize those things is an issue I see.
You have anything there, Dr. Brown?
Yeah, and I think part of it too is understanding what's impacting people in general, then impacting men, and then impacting Black men. So a lot of it to me is almost the behaviors or the symptomology of what's really going on underneath. We all might express things differently. And so I think about Black men not seeking medical attention and medical care. I think that's the issue with men all around, but with black men, it's really particularly much more of a concern because of a lack of education about the effects of certain ailments and of healthcare. The bad news of learning that you have to do more work or learning that there's certain health issues that you have are things that I think people generally want to avoid, but men oftentimes avoid because they feel overwhelmed with responsibility, overwhelmed with this need to kind of perform. But if they recognize early intervention could help them out, I think that would go a long way. I think another thing in addressing the unique needs of black men is really, again, to understand culturally who black men are. So having a lot of outside people kind of dictating that, it becomes difficult. You need to be able to consult the experts at some level. And so one of the hallmarks of counseling, of services, is to consult the client as though they're the expert on their life and not to dictate to them who they are or try to define them. So I think creating more space to kind of hear more from our patients, our clients, on what they need and how to best approach them would be a good avenue also.
Great, great. So I want to ask one more question. I think I'll open it up for question and answer. Dr. Turner, in your presentation, you really spoke a lot about stress and stress and the stress response appraisal and the coping. But we know stress cuts across a lot of different things, and it activates a lot of things in different systems in the body. I know this conversation is about mental health and brain health, but I just need to lift up, they're not mutually exclusive. And we don't talk about physical health, but stress, the physical health is where it starts. And so in your counseling, in your counseling or your engagement with black men, is there any conversation about the connectedness of physical health to mental health? And I know someone asked us about a distinction between mental and brain health. Do any of you all in any of your interfaces talk?
So one of the most basic behavioral conceptualizations of like changing some of these things is just to get active. What did Dr. Griggs say yesterday? Get fit, get moving, right?
Yep.
So if you think about it, one of the early signs will be the physical like symptoms of what happens, right? I'm sluggish, I'm exhausted, I'm not eating well, I'm not sleeping well, right? Once again, we're all adults, but Dr. Griggs gave me a lesson a long time ago. He said, hey, if as a man, if you're not able to perform intimately like you want to, that's a problem, right? And that's one that a lot of times will bring men into health, right? When they're not able to perform in an intimate environment, they'll say, hey, hold on, something's up, right? And so what I think happens is that making the connection to how your body feels, right? And not just intimately, but yes, how does it feel when you get up in the morning, right? I know as I get older, sometimes I got to stretch a little bit more in the morning or before I go to bed so I don't, be too bent out of shape, right? But if we don't make sense of the fact that our mind and body, unlike, Descartes told us, like there's a mind-body duality, right? There's a connection. So we have to be mindful of that. And so, yes, I very much will talk to my clients and I talk to students when I do talks. Like I said, that's a physical thing I want people to be aware of. How do you physically feel when you're stressed? I admit it. I walk around with a constant little tension in my neck. It's time for me to get a massage and to see a chiropractor, right? But I know this. So when it starts to hurt, I say, okay, Brian, I need to sit down for a minute because that little tension is there, right? If your back starts hurting a little bit too much, you got to say, okay, why is my back hurting? Maybe it's not that I actually have back pain. Maybe there's something going on and I need to stop. So there's a constant part of my assessment and evaluation with clients to engage them. How are you physically dealing? Are you able to go up a flight of stairs? Are you able to walk around the block, right? Louisiana, for some reason, we keep being at the bottom in terms of physical health, but sometimes we tell them, look, man, you got to walk. You got to get up and you got to get moving. Because then the piece becomes, there's the connection to when a person is physically fit, that it does help their mental health and their brain health, right? So there's the connection and people see it. So yes, getting out and behavioral components of therapy work just as well as some other things. So yes, getting up, walking, going and playing basketball with your children or your friends. Sometimes it is like, it's about to be Mardi Gras, right? I was laughing the other day about how as a kid, I would walk from Canal Street to Napoleon and never think about it. Now I only want to walk down the block, right? But if you think about it, sometimes it is. What do? We get together as friends. Like, let's go walk and we talk, and that helps us to get through that time. So definitely physical health, mental health and brain health all are connected, and we have to make sure that brothers are engaging and taking care of themselves physically to address those needs, because it will connect and help them with their mental health needs.
Thank you. Either one of you have anything to add?
Yeah, I'll echo Dr. Turner. I think a lot of it is being intentional in that activity also, because a lot of times we'll be busy, we'll be moving around doing things, but we have a lack of intentionality in really focusing on our health and making sure that we're doing stuff for wellness. So I think intentionality is a big piece also. I think when you think about stress too, there's a lot going on emotionally in the landscape. And so we talk about religion and getting back in touch with our churches and the community religiosity, but also to make space for the spirituality of people, kind of exploring who they are and how things impact them, how they feel emotionally with inside themselves too.
I gave a talk on the difference between brain health and mental health in a Black community kind of presentation a few months ago. And the World Health Organization actually has definitions for brain health and mental health. So, I was happy that I didn't have to make up some definitions on my own. But I find that, people still there's still a stigma just broadly with mental health, the term mental health, across all communities, especially in the Black community. And so I go about it as a brain health approach, like your brain. People can think about that easier. It's an organ, or, it's an organ, just like, hey, if I have diabetes, I'm thinking about my kidneys and things like that. And so I bring brain models into my talks, and I pass it around so people are like, this is your brain. This is what it looks like. I can tell you where emotions are centered. I can tell you where decision-making is housed. And I think that helps people to kind of actualize and realize, like, oh, wow, like this isn't just some abstract thing up here where it's just empty and, words are just appearing. Like, what is a thought? What is an emotion? It's neurotransmitters. It's, electrical stimulation of a neuron and things. Like, I can tell you where things are going on in the brain. And when you make it real in that way for people that, like, hey, you have high blood pressure, you're at risk for strokes. I can tell you where that's going to damage your brain. I can show you what could potentially happen. And I think those, just making it real and concrete, gets people into the door more to say, like, man, I actually need to take care of my brain. I was diagnosed with sleep apnea recently. And when I give talks on sleep apnea and I tell, like, do you actually know what's happening in sleep apnea? Like, do you legit, like on a physical level, what's actually happening? People just look at me with just shock and awe, like, dang, I didn't know that was going on in my brain. And I'm like, yeah, take care of your sleep. Go get it checked out, right? Because if the mind goes, well, what use is the body, right? And so when I break it down to them, I try to make it real in that sense, because I think we need to know that this is the stuff that's going on.
Thank you. So now we're going to go into the question and answer period. I know that there were two people that had questions in the audience prior, and there was one question online. I want to read the one question online. We have about 10 minutes, so can we tighten up the responses, please, to maximize the number of answers we can get? This is what I do. Here we go. Here's the question online to you, Dr. Turner, is have you noticed a correlation between the breakdown of the married Black man and woman family unit and the reduction in Black men health?
Have I noticed the reduction in?
Yeah, it's a long one. Have you noticed a correlation? Yeah, exactly, right. Not the second question, just the first one.
Okay.
Yeah.
Okay.
So
what I would say to the question in regards to marital relationships is that the easy answer is yes, because the family unit in and of itself is a protective unit, in terms of the ability for men and women and families to take care of each other. So the family unit, and that could also be the extended family as well. So I would say yes, but I also say that once again, we got to think about what resources are available, right? So if families and if members of families don't have the resources available, it might not be that the marriage or the relationship suffers. It might be that there are things that the marriage relationship just can't endure without help. So I would say it's both a yes and an or and a but.
got it. Thanks. So there was two questions. Yes, this gentleman, and then where's the other question? Okay, we'll go to you next, ma'am. All right.
Turn the mic on.
Turn
your mic on.
Yeah, make it hot.
Good morning.
Morning.
Retired robotic engineer. 25 years of prison ministry, where I've seen let me put it the real way, seen the same black human mind make the same black human mistakes that gets the same black human body incarcerated. So that's been my study. And my question that I want to bring up to the things that you was talking about, can you speak on the internal conversations that we have between me, myself, and I, per se? And again, from a black man's perspective, when that saying, it is what it is, and we all know where that saying came from, but when a black man says it is what it is versus when a Caucasian man says it is what it is, we're talking about our surroundings that we have to survive from. So in my studies, again, subconscious behaviors that affect conscious decision making. And I just, again, I'm here seeking more clinical advice, PhD advice on these subconscious behaviors that affect conscious decision making versus a saying like that, when we know it's a different, it is what it is for us. And again, what you were saying earlier. So
Yeah.
that topic.
We got you.
We got you. This, if anybody got you, they got you.
One of the cohort 1 members, Casey LeDuc, is a neuropsychologist in New York, John Jay College, CUNY, and he does a lot of work in criminal justice system and looking at health disparities in incarcerated and formerly incarcerated individuals. And I do a lot of work as well with public defenders, where evaluating people for criminal responsibility, competency, but also like death penalty cases and things like that. And the majority of those situations, most of the men often have undiagnosed or underdiagnosed learning disabilities, intellectual disabilities, underdiagnosed issues related to trauma and things. And so when you talk about the unconscious, becoming just these repetitive conscious behaviors and things, oftentimes there's things going on with these individuals' brains that were missed, that if they were adequately treated or helped on the front end, these individuals might not end up in the criminal justice system. When they talk about the school to prison pipeline, it's real because of just those issues. And so when you're working in your prison ministry and individuals are getting out of jail or integrating back into the community, we help them with mental health and okay, we're going to line you up with a job and resources and things. If that individual has a learning disability or intellectual difficulties that have not been identified, and I can't process things on the same level that I need to function in a day-to-day job, I'm being set up for failure. And so in your work, if there's opportunities for you to partner with people who do evaluations to help, hey, this individual, they were missed. And so that way, now they know, now I have data to know that I never knew I had a learning disability. I never knew I had trouble with math. I didn't know these things. And so I don't even know, and yet I'm being asked to work in these industries where it's asking me to rely on this weakness and I can't make it work. So I think, being able to give them all of the treatment and the resources that they need is going to be important for them to be successful.
Thank you. All right, we're mindful of the time. I want to make sure we get the third person. She had a question from the last time, so let's make sure we get to her. And then with time permitting, we'll get back.
I'm sorry, I'll try to make it quick. My name is Eliana, I'm from the University of Michigan. I really appreciated hearing about Dr. Turner's, the ways in which kind of culture intersects with mental health and with coping. I thought that was really illuminating. And I was curious about how you also envision things like generation impacting this as well. And so I know that depression tends to peak in younger adulthood and then in older adulthood as we lead towards kind of risk for neurodegenerative disease. And so I'm just curious how you see generation impacting that as well. Thank you.
Well, I mean, I think it's just once again going to be embedded in the approach that I take to do assessment and evaluation for those types of things. I'm always going to lean to trying to be a good, accurate historian of stuff. So when the capacity or the ability is there to gather that information about family dynamics and family relationships, that's always helpful. And I'm always just going to lean back on the point, right, is that like culturally competent providers are going to take time to find out the things that matter, right? And so I'll just, for a brief narrative, I have a client I've worked with for a while that one of the earliest things I said to him was, hey, man, you want to be a perfectionist, huh? Nah, man, I'll just take it how it is. As a brother said, it is what it is. After some time, he said, man, I got to be perfect. I said, oh, where'd that come from? What do you mean? I said, well, I asked you before about that. And so then he gives me this long story about how as a little boy, having to take care of his mom and sister, as a little boy, he learned that he had to try to be perfect. So I'm like, so now as an adult, you think you have to be perfect because the pressure was put on him. And honestly, it wasn't his mom and his sister, it was him. He adopted the mentality he had to be perfect because he felt like he had to be the man in the house. So once again, sometimes it's the work that we do over time to extrapolate this information and pull it out that clients don't even know are impacting them.
Thank you. One final question, brother.
First, I'd like to, I'm Dr. Toykas Westbrook, Howard University, Meharry Medical College. First, to the virtual question that came through, African-American marital rate is at an all-time low. And I think that's a direct result of the black men brain health. Bottom line is black men, I'm one, are under increasing amounts of stress in this society. And when you're fighting that many demons in order to prosper, the aspect of partnering with another individual, especially a black woman, has some confounding problems to solve in order to make that work. But my overall umbrella question I want to ask is, let's talk about lifespan. What's being done about lifespan? Because there's a study amongst graduates of my medical school that showed that physicians die at age 59 because of the lifestyle and the stress that goes along with achieving the degree and then going out and practicing. Well, I think that is an even broader context. What's the lifespan of the black male? We know it's lower than other ethnic groups, and what's being done about getting to black males at an earlier age to say, hey, take care of your mental health in order to increase your lifespan.
Thank you so much. Anyone want to take a shot?
Yeah, as far as like how do we approach them earlier, I know we've been doing some of that with medical tests, making sure you get in earlier to check on different things, but we need to apply that to mental health. I think really overarching what I see happening with black males is that the masculinity we talk about sometimes can be identified as hypermasculinity, and I think that's a misterming of it. It's really a suffering masculinity. And it's the type of suffering you see from empowerment all the way to success. It's to be a man means to suffer and to bear this. I think that's also familiar what it means just to be black at some level. It means to suffer. And that suffering has a stressful impact, and I think it does shorten our lifespan, and it definitely undermines the quality of our relationships, especially when there's shared racial trauma within some of those relationships that's undermining the marriage numbers.
And
Real quick, because we're out of time. I just got the 1 minute mark.
all right.
You're a little long-winded.
Okay, I got you. And I would add to that as well the ability to notice and respond to internal signals, like when we're having physical pains. Like we tend to, as black men, turn those off at a very, or learn to ignore them at a very young age. And so when we do get those signals, we just ignore them and say, oh, it's fine, it's not anything. And so that can also lead us to being enduring more chronic health issues that are a problem.
There he is. Finally, we got him. We came together. Hey, I'd like to close by saying thank you for those words of wisdom that we have. Thank you for those words of wisdom that we have for the panel. And Robert, do you have a question?
I have one question on to close us out on. It could be anyone or you could all, but can you give us some good news? What's good that you know about black men's brain health?
And about, because I'm getting pressure from this one. So everybody got a 30-second bite, right? Because I'm getting pressure from the coordinator right over here.
Okay.
So,
Well,
right.
I think some good news I know about black men and their brain health is that we have a very versatile brain, very creative, very adaptive, and I think that's something that we need to value and not feel that it's a liability, right?
I'll second that. I just think that in terms of black men, especially young black men, the creativity, intelligence, thinking outside of the box, that when molded right correctly, black men can do a lot and do a lot of great things. Just taking the time to get to know how black men think.
Dr. Turner, take us home.
So what I'll say is this: what I know that's good about black men and our health is that we're still here.
Yes.
We ain't,
That's a clap right there. Yes.
we ain't going nowhere. We ain't quitting. We ain't stopping. We done been dealing with this for over 400 years, so the fight still goes on. Take time, give black men the love, care, direction they need. They want it.
Thank you. And we're going to end on that note. Give them a round of applause.